Now our IFORS president, Jani Luong, will kick off the webinar. Over to you, Jani.
Thank you. So I would like to welcome everyone. Good morning, afternoon, evening to this webinar. Before we start, I would just like to say a few words about IFORS, just in case there are attendees who may not know about IFORS. IFORS is the International Federation of OR Societies with the objective to promote the development of OR worldwide, both in theory and in practice. It was founded in 1959 by the three national societies of the UK, USA, and France. And after now more than 60 years, we have over 50 national societies with a total individual membership of over 30,000. IFORS is divided into 4 regions, and of course today's webinar speaker also represent each of these 4 regions. We promote OR through a list of activities. You can go to the next slide, Christy. Through our conferences, distinguished lecturers at different regional conferences, our journals, and particularly this, our global webinar series, and other communications. And particularly, we want to promote OR to younger researchers through our summer and winter schools and support for new OR societies worldwide. All these activities are overseen by members of the administrative committee. Christy, you can advance that slide. Of course, Professor Wismar is the moderator of this global webinar, and other vice presidents have a responsibility for each of different aspects. I just want to highlight a few things. Next slide. Every 3 years, we have an IFORS conference where researchers and practitioners all over the world can gather, and our next one will be next year in Santiago, Chile, and I encourage you all to consider attending. We also promote OR through our 2 journals. The ITOR, International Transaction, has been our flagship journal for over a decade. We have a new open access journal, Sustainability, Analytics, and Modeling. And because it's new, IFORS will actually pay for the publication fee for submissions through the end of this year. You can also find out more about IFORS activities through our quarterly newsletter, which is freely available from our website. You can actually subscribe through the website, so it will automatically come in your email as well. And through this, we can advertise and read about all the activities worldwide related to OR. One of our big projects is, of course, this global webinar series, which has been started since July 2020. So you can see all the past webinars also on our website. So for other activities, I encourage you all to look up everything that we do at our IFORS website. And with that, let me hand over to Professor Speaksmar, who will begin this global webinar.
Thank you. Thank you very much, Jani. Yes, welcome to everyone out there. Welcome. Till 3 years ago, the word pandemic only stirred images of the past, like, the Spanish flu or even medieval plagues. And now, all over the world, we all have experienced what it means to live under a pandemic. As I see it, science has saved us from the most severe consequences, but nonetheless, the impact, and I'm saying cliches here, the impact of COVID-19 is, of course, huge and will continue to remain significant in the coming years. Now, operations research is obviously in itself not a medical profession, but we do deal with, scarce resources. And in our community, all over the world, and this seminar is a good example of that, of course, all over the world, our colleagues have been applying our tools to COVID-19 caused situations. So today we're going to listen to 4 great stories, and I'm actually quite proud to be able to introduce each of the 4 speakers, the first of which is Professor Sheldon Jacobson. He's a founder professor of engineering at the University of Illinois in Urbana-Champaign. His research spans theory and practice, ranging from college sports analytics to decision-making under uncertainty. And I guess the common denominator in his works is to strive to make the world a better place. And with that, I give the floor to you, Sheldon. Please go ahead.
Thank you very much. It's wonderful to be with you all today, and we will pull up my slides. There we go, from the beginning. Thank you once again. I want to say good morning, good afternoon, and good evening to everybody who is with us today. It's a real pleasure to be with you, and thank you for the opportunity. You know, every one of us has been impacted by COVID-19. Think about where you were in December of 2019 or January 2020, and you will then think where you are today. And what you'll discover is that your life is radically and dramatically different. A lot has changed for all of us. And in many ways, every crisis presents an opportunity. And I'm sure each and every one of you have discovered that yourself. So one of the things that struck me during the pandemic, and this of course focuses around the United States, although many of the ideas I think are applicable in other countries, is how we report the worst outcomes associated with COVID-19. And in many ways, it became very, very confusing for people to get a full grasp and understanding. And the thing that came about in this discussion with my colleagues as well as my students was excess deaths. You know, where are they? So we started to look at these excess deaths, and people have looked at this in many different ways, in many different dimensions. We're going to talk about it in a very particular dimension. This is joint work with Ian Luden, who's a PhD student of mine here in computer science at the University of Illinois, as well as Janet Jokala, who is a physician, as well as has a master's of public health, so is a public health physician as well. She's an infectious disease doctor, and I have the great fortune to have her as my wife. So as a result, here she was in the little lower hand. She's one of my great passions of life. So we've all read in the media what is happening in terms of excess deaths, and some of it has been in the more popular press, some of it has been in medical journals where people have tried to look and uncover what's happening here. Why is this happening? What are the lessons learned? How do we inform the population of what's really happening with COVID-19? Now, some people think it's nothing more than a seasonal flu or a cold. Others view it as being like the Black Plague and everything in between. So in essence, there's been a tremendous societal shift which has occurred. And the question is, how do we take the data to extract it, to provide some important and useful information for all of us to gain a better understanding of really what is happening? So this drove us to pose some questions which are data-driven and try and in fact use the data available to help us in fact gain some insights. In particular, looking at mortality rates, now that we are in 2022, we can look at mortality rates from 2021 and 2020 and compare them, as well as look as a baseline in the previous years before the pandemic hit. Of course, we also want to look at the fact that there are many deaths that are occurring that have nothing directly to do with COVID-19. And the question is, how have they changed? And then the real question is, are we going to return to what we had in pre-pandemic levels? Will this ever occur? So these are some of the questions we wanted to explore to get some insights into the impact of the pandemic on people's lives, in particular mortality. Because if someone dies unexpectedly, or more accurately, prematurely, it affects many other people in their family and their friends, their coworkers. Each and every one of us likely knows or has been in fact touched by someone who in fact has died from COVID-19. And this is something that this was unexpected and certainly a premature incident. So what we wanted to do is find out first what data was available and then how we can use it. In the United States, the Centers for Disease Control and Prevention, the CDC, provides provisional mortality reports every week. In fact, on Wednesday, we're going to, in fact, get our update later today, and it gives the total deaths for the week. It also gives deaths which are directly related to COVID-19 as well as not. And here is somewhere which something that has in fact confused a lot of people, because the question becomes, have you died with COVID-19 or have you died from COVID-19? And the distinction makes it very, very difficult for some people, especially those who are skeptical that we've been through a pandemic and are still, at least on the tail end of it, that this is real, because people are dying simply with it, not from it. They have other comorbidities. And the reality is that may be true, but it doesn't change the fact that they're dying. And ultimately, they're dying before they should, prematurely. We also wanted to look at the effect on gender as well as different age groups, because it certainly has not affected people the same way. In terms of baseline population and size, as well as population deaths, the CDC has a wonderful website, interestingly called CDC Wonder, which we're able to get population and death data from going back for many, many years, in particular 2015 and 2019. And the last update was from last Wednesday, so we'll have another update today. So if you want, we'll give the talk again tomorrow, but we're not going to do that, of course. So here's something that you may have heard about, but now you can actually see in a graph, where the number of deaths, and this of course is in the United States as well as the year, and we see from 2015 to 2019 with population growth, there has been a very slow and steady increase in the number of deaths in the United States. It runs in the order of around 58,000 people every week in the United States are dying, give or take a few. And some weeks are higher, some weeks are lower. During flu season, it's a little higher. It kind of troughs down during the summer and gets higher again later in the year. But now we go to 2020 and 2021, where we see that there are clearly some deaths that are attributed or associated with COVID-19, but there are these other deaths that are not. What caused them? Right now, it's speculation, although we're starting to get a better picture of it. Screenings for cancer, for example, and other chronic conditions, and even become acute conditions, are leading to people dying prematurely. And there's been an opioid crisis in the United States. More people are dying from overdoses, more automobile accident deaths, ironically. I mean, where did this come from? People were driving less during shutdowns, yet more people have died from automobile fatalities. So we start to see the societal impact and how there's been this transformation, which has occurred based on the fact that we're living in a world with a pandemic. And these excess deaths are not associated or attributed to COVID-19, yet they have occurred. And this becomes a very important indicator that there's something different that's going on. And as much as people say that the pandemic is only a cold or nothing more than that, the reality is people are dying at a rate that we have not seen, unprecedented levels, impacting life expectancy. In fact, the life expectancy in the United States went down in 2020 and even went down in 2021, although in many other countries it actually rebounded. Once again, the big question we always ask is why? Do we have enough data to assert what the why is yet? Not yet, but it's certainly something that we're thinking about. So now look at a plot, because there is simple random variation in depth. So if we look at, and this is going back to April 2020, we see that there's a certain number of deaths associated with COVID-19. And then there's also the predicted number of deaths that we would have expected based on just seasonal variations. But then we say, okay, based on that variability, that uncertainty, there's a certain level beyond which you would say, okay, these are in fact going to be excess deaths. And we see those little, crosses, those little red crosses. And this is, in sense, tells us that this is above the threshold that we would count this as an excess death. Just because you have a few more deaths doesn't mean it's excess. There's certain variations. And we see the tremendous number of excess deaths that have occurred in the United States going back from April 2020 to April 2022. And we, of course, had the big surge back in the beginning of 2021, late of 2020. And we've had some other surges since then. The first, we also had the Delta surge, the Omicron surge. And what we're observing is that there's a tremendous number of excess deaths, not only associated with COVID, but also just occurring. And this, of course, is the most disturbing aspect when people say this is nothing more than a cold. Clearly, it's much more than a cold, and it's affecting people's lives in ways that were unpredictable and, quite frankly, dangerous. So what did we do? We wanted to look at the death risk through a variety of measures. In particular, the death risk is basically, and there's different ways to do this, and in the In the health community, they use odds ratio. You can use risk ratios, but we just followed what the public health community uses. And it's the ratio of the number of deaths to the number of people who aren't dying in a population minus deaths. We can then take that for different time periods and take those ratios of the death risk to come up with the odds ratio. And from that, we can then construct confidence intervals, which enable us to, in fact, then get a sense of how reasonable it is that there's a difference in risk, in particular death risk, between two time periods. We give a simple example here. So we took a 35 to 44-year-old females comparing 2021 versus the 2015 to 2019. We looked at the death risk for each of those. And when we take the ratio of those death risks to get the odds ratio, and then we constructed 99.8% confidence intervals. Why did we construct such, in fact, precise confidence intervals? We did that because we wanted to know that when we're looking at multiple confidence intervals, what confidence do we have across all of them? Basically, we're trying to overcome the Bonferroni effect, which many of us, of course, are very, very familiar with. So what were some of the things that we observed here? Well, first, we looked at a comparison between 2021 and the 2015 to 2019 deaths. And this was total deaths. This was not taking out the COVID deaths at all. And what we saw is that for very young people, of course, these are infants as well as 1 to 4-year-olds, the odds ratios tended to be below 1, which means that there was a greater death risk in 2015 to 2019, which would suggest that the pandemic has been protective to them, which of course is not really correct, but it certainly has reduced their risk of mortality. On the other hand, just about every other group, and we often think of people who are younger and in middle age not being affected. The fact is that their, in fact, odds ratios are quite significantly larger than 1 when we compare 2021 to, in fact, 2015 to 2019, the average over that time period. So as a result of that, we realize, oh, there's something really happening here. At the same time, if we focus our attention on just the non-COVID deaths, which of course really are what's happening outside of the COVID impact, although the impact still exists in society, we see a similar effect, except if you look at the older people basically that are 75 and above, we see that their odds ratio has fallen below 1. And you may say, well, how's that possible? I mean, clearly COVID-19 has impacted the elderly the most. But what we believe this suggests is evidence of mortality displacement, which means that the people who died in 2020, they died prematurely in that age group. And as a result of that, since they didn't die in 2021, which they would have, then they're dying earlier, those deaths just aren't occurring. Now that we have vaccines, which are available in 2021, those people are better protected, more precautions are in place. And the irony is that they died early, what we called mortality displacement. So this was just an interesting insight that we were able to extract. We did not see that effect in the people in the younger and middle age groups, where we see people, for example, from 15 to 24, 25 to 34, 35 to 44, and 45 to 54. We didn't see that effect quite as much. The other thing that we extract from this is men tend to have a worse outcome than women. We know that from the observations which have been done clinically, but we also see that in the data in terms of fatality risk. So this was a rather interesting observation that we made based on using the data that was available. Well, the other thing is, well, what's been happening over the 2 years of the pandemic? Has there been a significant change? We saw, of course, that vaccines were introduced in 2021, and we've had them now in 2022. Do we see a similar kind of phenomena that we just described? Well, in some sense, we see some interesting observations that come out of this. If we simply look at total deaths, once again, the elderly, in this case, people who are above 65, although it starts to bleed into 55, but we see this odds ratio being, in fact, meaning that there was a greater death risk in the first year compared to the second year. While for the people who are, in fact, in that middle age and young middle age group, we see that there's a greater death risk in the second year rather than the first year. And this was a rather interesting observation because, of course, vaccines have now been available, and you would think, well, it should kind of smooth itself out. But in reality, that is not happening. And these are statistically significant based on the confidence intervals. When we get to the younger people, once again, the risk for the 1 to 4 year olds and the less than one are pretty even, but the 1 to 4 year olds slightly more in the second year rather than the first. And once again, this is total deaths that we're talking about. At the same time, if we look purely at the COVID deaths, which is what people like to report and talk about, things are pretty smooth right across the board based on how the confidence intervals, in fact, are breaking that 1.0 odds ratio threshold. The only group which has a slight tendency that there was greater risk in the first year versus the second are the elderly, the oldest people, 65 and above, which is in fact not surprising because we've had vaccines and this group has had the largest uptake, certainly in the United States. So this gives you a little bit of an example of how the data is speaking to us. So what are the key findings here and the key conclusions? For most of the subgroups, there's higher death risks in 2021 versus the kind of the baseline pre-pandemic. And also the excess 2020 deaths displaced some of those 2021 deaths and likely beyond. So we're probably going to see this effect occurring for a few more years, especially for the older, until they would have naturally died anyways. And the second year of the COVID-19 pandemic appears to be much harder on the middle age, which this group thinks, oh, I'm safe, I'm protected, but the data does not say that actually. The data says something much, much worse for them. So what are some future issues that we're going to look at? In fact, we've published a couple of papers on this. We have a third one, which is now under review, which talks about the stuff that we just discussed today. As more data becomes available, we do want to break it down much more, especially with the non-COVID deaths, the causes of the deaths. You know, why are people dying? I think this is an important question that we have to discern because this can be very, very helpful for us to understand the phenomena of what we did to respond to COVID-19 and whether some of these things actually had unintended consequences. Ultimately, we want to look at what's going to happen in the steady state. Are we going to return to a baseline similar to what we had pre-pandemic? And nobody knows for sure that. We're only 2 years into the pandemic. And then what are the lessons learned for future pandemics? Can we extract some information and find out how we should be responding when we have a respiratory disease which is transmitted through aerosol transmission? How are we going to deal with this in the future? And we want to make sure that we don't simply look at a narrow focus of deaths from the disease, but look at the grander societal death impact. And I think these are important questions that the data that we've been looking at tries to extract and hopefully inform people. So we find this very, very interesting, and we hope that you have found this interesting and that you continue to be careful, of course, be vaccinated if available, wear face masks when appropriate, and stay safe all the time. Thank you very much.
Thank you very much. Thank you very much for this very nice and very informative talk. To everybody who's out there, remember, questions can be asked after all speakers have given their presentations, and you can, of course, always type things into the chat. I'm going to proceed by introducing our next speaker. That is Koole. Ger is a professor / entrepreneur. His professorship is at the Vrije University of Amsterdam. His entrepreneurship used to be more call centers and nowadays in healthcare operations. And besides all that, he is a prolific author. During the pandemic, Ger and his colleagues developed a model for predicting occupancy rates in Dutch hospitals. And if I'm not mistaken, that is what you're going to talk about now. Please go ahead, Ger.
Yes, Frits, thank you very much. That's indeed what I'm going to talk about. So let me right away start with what this project was about. In the end of 2020, at what we call, in different countries had, of course, different waves at different moments, but what we called the second wave. After the first wave in March 2020, there was in the autumn of 2020 a second wave, and at that moment, perhaps a bit late, but with hindsight, it's always easy to criticize. But we were asked to develop a model for indeed predicting occupancy in the Netherlands. This is joint work with René Becker, also from the Vrije Universiteit here in Amsterdam, together with a postdoc out from Groningen, another university in the Netherlands. So let me first give you the context. So the Netherlands, although it's a pretty small country, we have, I think, around 17 million inhabitants on a pretty small space, highly densely populated country. We are organized in 8 acute care regions, and here in blue you see a picture of the Netherlands, and here in white you see one region, and here it's Amsterdam, Rotterdam, Groningen, the big cities, The Hague, so some big cities, and for different reasons, the infections and the admissions to the hospital because of COVID were different between regions. Actually, in the Netherlands, it's all started when people who went on skiing holidays in Italy came back in early March. At that time, the southern part of the Netherlands was on holiday, and that is also the Catholic part of the Netherlands. And they celebrated Carnival, and there, of course, large groups of people together. So there was a huge spike in COVID infections and also hospital admissions in the south, while especially the north was not touched at all by COVID. So for that reason, people decided, and like the national body, which is called LCPS, which means National Coordination Center for the reallocation of patients. They were in charge of reallocating patients between the different regions, and potentially also to Germany. Now, to do that, you don't want to reallocate a patient from one region to the next to realize that perhaps the number of patients in the first region drops or increase it in the second region, and that you have to reallocate the same patients a couple of days later. So to make to do these reallocations in a good way, they needed predictions of the number of COVID patients in hospitals. And that is exactly what we were asked to do. Before that, they used a simpler model, and there was little confidence also by the regions in these models. So people were questioning, are we doing the right thing? Are we doing the right reallocation? So therefore, they asked a couple of mathematicians with experience in healthcare to make a better model. And that's actually what we did during mostly during October. Our model is October 2020. Our model is still in use, and one of the authors, Michel Uiterbroek, he is still working for the LCPS. He actually stopped at the university, and René and I, well, after having built this model, we basically stopped with our work for the LCPS. So what is our approach? I'm now going into a bit more technical details about what we actually did, without going, of course, in all the mathematical details. There will be a paper in eJOUR about this, in the special issue about COVID. So if you're interested, you can download that from the eJOUR site. What they needed was a short-term prediction of the number of patients, both in the clinic and in the intensive care at the regional level. So if the yellow bars are the current occupancy, then they needed a prediction for, say, the next week. And what we did, we separated that in two problems. One is to predict the arrivals for the next week, and the other thing is both using the length of stay of both patients already in the hospital and patients arriving predict the occupancy. The first thing is predicting arrivals. Now, if you ask somebody how to predict arrivals in a hospital, the obvious answer is, well, you just predict the number of positive tests, and perhaps these people, they arrive 1 week later, or at least a fraction of them arrives 1 week later in the hospital, and that's your prediction. So you use an external variable, the number of infections or of registered infections, to predict the number of arrivals. Well, there are a few problems with that. In the first place, there were a lot of policy changes, and in the beginning there was no tested at all. If you look here at the figure in green, you see the number of positive tests divided by 25 to put it in the same figure. In red, you see the occupancy at the intensive. These are the arrivals, not the occupancy. The arrivals at the intensive care, and in blue, you see the non-intensive care arrivals at the well, usually a specialized COVID ward, but not at the intensive care. In fact, it takes some time before people realize they're ill, before they get a test, and the time until the infection and actually a confirmed infection with a test, etc., is about as long as it takes for somebody to get really ill and get to the hospital. Yeah, so that means there is no time lag between this. Next to that, the infections, as I was just saying, there were lots of policy changes in the beginning. There were very little tests. You can see the green figure is really low, got higher. And then there were different things in the news. Then at some point, different groups of people were allowed to be tested, etc. So lots of changes in testing. And in the end, and we also did the statistics, of course, the tests, there is no no predictive value in using tests. So what we ended up doing is using actually the historical data on the admissions to predict the admissions. Yes, and it seemed counterintuitive, and people perhaps like this idea of using the number of positive tests, but this is what worked best. So we developed a model to do this, and perhaps interesting, certainly for our community, instead of some standard statistical model, we used actually linear programming as a prediction model. And what is interesting, what you might have seen from the previous slide, is there's also a seasonal effect in the data. And now I'm referring to the intra-week seasonality, because typically people first go to the general practitioner when they're really ill before they are sent to the hospital, unless they're in such a state that they're transported by an ambulance. But this is the common way to do this. Now, general practitioner usually don't work during the weekend, so there are peaks on Friday and on Monday with the arrivals. So it is important, and interestingly, certainly in the beginning, if you read the journals, they were saying, okay, there are so many more arrivals than yesterday, and then the next day they say the numbers declined. Of course, if you do not realize there's a weekly seasonal pattern, then you have something new to report every day, because it's you're just reporting the seasonal pattern. So that's one of the things we took out. So our model, as you can see here, it consists of a trend and a seasonal component, X plus S. That is our model, and we want to fit that to the log of the actuals, of the actual number of admissions. The log, because the seasonal patterns are typically multiplicative. So this fits our curve or a model to the data. And then we have a penalty term, and it's a bit like a smoothing spline in statistics, but then discretized. We look at the second difference of the trend model, and we penalize that in our objective function. Yes, and this is a linear model. Of course, The absolute function is not linear, but that can easily be linearized by introducing some additional variables. And this was actually the model that we got. And the nice thing, this second derivative, and also the first derivative, it's like a derivative. So what we also got out of this model is actually an R value, not based on the infections, but an R value based on the admissions. That's actually what in Holland our Center for Disease Control, RIVM, also did in the beginning, because at that time the data was still very much about, if there was no data about infection because there were no tests. Second thing we did is predicting the length of stay. Of course, this is sensor data, because there you do not know the full length of stay, because some patients, certainly in the beginning, the patients with the longer length of stay were still present in the hospital. So we didn't have full data. So we used standard techniques to deal with these sensor data. Here you can see some data from in the ICU length of stay, both in the ICU and in the clinic. Again, we used these distributions to determine how likely it is that the patients present would still be currently present, would still be present in, say, 1 week. And the same, of course, held for the new arrivals. We use there the length of stay distribution to predict the number of people that would still be present after a certain number of days. Okay, let's not go into the details about this fitting, but we then used, and here what I'm illustrating, we use that to predict the number. Again, one group is the patients currently present, and the other group are the patients still arriving. What I'm illustrating here, but I guess to a mathematical audience, I don't have to go into the details, is that the waiting time paradox plays a role here. And actually, from the data, you see that that was very skewed. So there were, as you often see, there was really certain patients that spent an extremely long time at the especially the intensive care, and currently the numbers have reduced drastically. But for certain, those patients who are still present at the ICU, there are still small groups of patients entering, but definitely those patients with a long length of stay are currently very much overrepresented. The predictions. I recently read a nice book by Daniel Kahneman called Noise, a popular scientific book, but I think still interesting for us. One of the points he, together with his co-authors, make is that we overestimate our capabilities in predicting things. That holds for doctors diagnosing patients, that holds for people interviewing new candidates for a job, that apparently also holds for mathematicians making predictions. We thought we had a great model that we would make very precise predictions. They were less precise than we thought in the beginning, but still good enough to be used for the purpose the model was built for. And also good enough to get the trust of all the health people, the health professionals involved. Sorry. So that was basically the model that we built, the two sides of the model, and later on that was built into a whole chain of steps in R, where the regions had to enter the latest numbers. Then automatically the model was built and the model was run, and the numbers were updated. And this over the last 1.5 years is what was used. Nowadays, there are no reallocations anymore, but there are still people at the LCPS, and people are currently speaking of keeping it up, even though right now there are hardly any patients anymore, or COVID patients anymore, to be able to be prepared for either a new wave at the end of the year, or perhaps other pandemics or other things that might arrive. There is one thing I would like to mention, and that this focuses very much on COVID patients. But of course, we all know there was also a consequence for other patients who had to wait because of COVID patients. Now, this was much harder to quantify. This was often less urgent, but sometimes perhaps equally urgent at COVID patients. And one of the things when discussing with the Ministry of Healthcare here in the Netherlands was to make them aware of the importance of that it's not just about COVID, but also about the delayed care. So we worked together with oncologists and cardiac surgeons to create awareness of that. And one thing which is more mathematical, I want to show you, is the following fact. Suppose that you have one wave, and that you have n patients on the waiting list, and and that you need T days to use your the capacity you have left over to work them away. So if you look at that, at the blue figure, yes, that the total volume of waiting is the surface of this triangle. Yes, so the total delay is n times t over 2. That's the total number of days of delay accumulated over your patient. Now, suppose that on top of that, you have a second wave. So now you have 2n patients. And of course, it takes 2t time to use your overcapacity to work away your backlog. But the impact, of course, the surface of the second triangle is not simply twice as big, it is 4 times as big as the blue triangle. So the impact of twice as many patients is 4 times as big. So while the general audience learned about exponential growth and decay, and when talking about R factors, reproduction factors, here we see a quadratic effect of the waiting list. Yes. So it is important to realize that 2 times as many patients doesn't mean doubling the impact. No, it means that the impact is 4 times as big. And so while we were at that time in the second wave, this was an important thing to realize. Doesn't mean that we had easy solutions, but it's something to realize. Okay, this is my last slide. So concluding, I think the model was useful. So it helped in the reallocations. And helped policymakers. We also contributed to these discussions on delayed care. In red here, some negative things, which is always hard working in healthcare. Of course, we as mathematicians are not in control of everything, and our optimization models, even if we think we are saying the right things, are not always accepted. So in my communications with doctors, and I personally know also some IC doctors, I think sometimes the wrong decisions were made, even when there was no reason because of a lack of beds to displace patients to, for example, to Germany, where there was overcapacity and way less pressure on the healthcare system. They didn't do it, yes, because for the IC patient with COVID, it's not the best thing to get reallocated, yes. But for the system as a general, it's way better because you can help cardiac patients, you can help oncology patients. So we are used to minimize or maximize some global objective and not look at one individual patient. Yes, and there are multiple reasons why doctors were not willing to do that, but I think that really, to be honest, frustrated me. And of course, these doctors were very much in the news, and they used their, well, one of them even used it to become the new Minister of Healthcare, which is an interesting fact. But they also used it to get health workers the first to be vaccinated. And I think that was a bad decision, and against also some advice. And I think it should have been those people most vulnerable, and that probably costed lives. Yes, it's hard to say, but I think that's true. Currently, situation in the Netherlands, luckily way better. Perhaps things will change this autumn, but for the moment, there are more flu patients than COVID patients in the hospitals. On the other hand, because still many health workers are ill, and because of the backlog, there's still a high pressure on the healthcare system. Okay, thank you very much for your attention. I'm sorry if I spent a few minutes more than planned, but
oh, that's fine. Thank you very much, Gerrit. Thank you very much for sharing your models and your acute observations. It's tempting to go for questions, but that's not what we're going to do. So thank you. As I said before, questions can be asked at the end. I'm now going to introduce our third speaker, Denis. Hi, Denis, I see you there. Denis Sauré is a member of the team that won the Frans Edelman Award for using OR to improve strategies for combating the pandemic in Chile. Now, to some extent, if that is your introduction, you do not need much more. But let me just simply add that Denis is from the University of Chile in Santiago, has an interest in service operations and revenue management. And I'm very much looking forward to his talk. Denis, please go ahead.
Now you can hear me, right? Hopefully. I can
hear you and I can see you. Cool. Yes.
Okay. Excellent. So I'm gonna be very ambitious this morning, afternoon, evening. I'm gonna try to summarize what we did for receiving this award in 15 minutes. I'm pretty sure I'm not gonna make it, but I'm gonna try. Okay. So this is the presentation, a summary of the presentation that we gave to the Edelman judges. This is joint work with a lot of colleagues from academia, and I try to list them here, but I should have included hundreds more because this most of the work that you're gonna see now, it was actually implemented, and it was implemented by people in the field. Right. So let me start by saying that this was a joint work between academia, public sector, and private sector. So we presented ourselves with we were the Institute of Complex Systems, which is a research center with more than 50 faculties from several universities in Chile. We presented the work that we did with the Ministry of Health of Chile, with the Ministry of Science of Chile, and with a private company, a telecom company, Entel, which is the largest company in Chile. And you'll see why. I didn't risk to miss anyone, so I just listed all the authors in this work. Where you have in the first line the people from the academia, from the engineering side of academia. Then you have the people from Stanford, then the people from Entel, the telecom company, then the people from the government, people from the Faculty of Medicine of the University of Chile, and then the research assistants. Right? Okay, so let me spend a couple of seconds saying a little bit about this EASY Institute. This is a research center that receives a lot of funding from the government. So as soon as the pandemic started, the leadership of the institute says that we have to essentially put all our efforts into try to fight the pandemic with our research. We did a lot of stuff. I'm just going to talk about 4 initiatives that were included in the Edelman project. I'm going to start with mobility. And mobility, I mean, is essentially study of mobility patterns. Why? Because this is a timeline of the pandemic in Chile. You have the first wave, and in the first wave, yes, we started like everyone else, essentially trying localized lockdowns, and we didn't know if they were working. Okay, and we didn't have data to answer that question. How are the lockdowns affecting the population? Okay, and I included the map of Chile here because it's gonna help you create some type of context to see how logistics were somehow difficult at times. Okay, so there were the first lockdowns, and we know how these were working. So what we did is we started trying these epidemiological compartment models to study the evolution of the virus. Soon we realized that a key piece of information we wanted to try to have a success in modeling this stuff was that we needed mobility data, and we didn't have that mobility data. The data that was available, for example, from Google, wasn't granular enough to model this type of models. So what we did is we approached Entel, which is the largest telecom company in Chile, and we asked them if they could facilitate this data. They gave us, actually it was a joint project, so we shared the data on the use of the cellular infrastructure, and we somehow managed to be able to construct these origin destinations matrices that will tell us how people was moving every day, every time of the day, from one census block to another census block. Census block is essentially the most granular unit of space that we work with preserved anonymity, but still allow us to do a lot of a rich analysis of mobility. Okay, so we brought Intel with us, and that allow us to come up with this type of analysis. We tell the population, because we made this type of dashboards available to everyone, how effective was the pandemic. Okay, so here the zero level, the base level was the mobility pre-pandemia, and here we have by county in Santiago. No, this is here by Santiago, how mobility was reduced. Okay, and we soon realized a couple of things. First, the pandemic was not affecting all counties equally. Actually, it had a greater effect on high income areas, and low income areas had a lesser effect, which was something, a valuable piece of information that we were able to provide to the authority. And we realized that actually the lockdowns were progressively less effective. Okay, so at some point, after realizing this, the authority, they switched to like a global, not national but regional type of lockdowns, and they put more effort in trying to provide a health, another type of health, and not just lockdowns to palliate the effect of the pandemic. This is what I was talking about the effect of on high and low income areas. So that was the first project. We received a lot of attention, and we gained a lot of trust from the government, and they start to look at what we were able to do. And that takes me to the second project. I'm gonna go really fast because this is pretty much like what Gerald was just describing. During Gerald's talk, I found myself essentially nodding for 15 minutes, because the type of models that he described and the type of efforts that he described were exactly what we were doing. Okay, so this is the scenario in terms of the timeline. There were two huge waves in Chile, pre-Omicron wave. The first one and the second one for us was when the Gamma variant was rampant, and we didn't have a high effect with the Delta variant, because at that time we already were vaccinated. Okay, so at this point, occupancy of the ICUs were above 90%, and during the first wave, we were contacted by the Ministry of Science, and they asked us to provide a short-term forecast of ICU occupancy. And the work we did was essentially what Gerd described. The ICD compartment model is essentially the model that is very much like the model that Gerd just described. We did this in a very short period of time. Just to be sure, we throw everything we had to the forecast problem. So we tried autoregressive models, we tried machine learning models, we tried neural networks, and the outcome of this was an ensemble forecast. And the ensemble forecast proved to be better than just any model individually. We presented this type of reports to the authority. These are the predictions for ICU occupancy 1 week and 2 weeks ahead of time by region. The way Chile handled the ICU occupancy was peculiar, but was unique probably, because the government took control, not only, it took centralized control not only of the public beds, they also took control of the private beds. So they operated a whole centralized system, and this information was key to for example, plan how to move people from one region to another. Okay, so I'm not gonna expand myself there. The third effort that we included in this initiative was the screening of asymptomatic cases. And going back to this timeline, right after the first wave, we had this period of time in which positivity levels were finally dropping below 10%. About that time, we were in the institute, we were really pushing for applying the pool testing strategy. I hope everybody is familiar with pool testing. Essentially, instead of using one PCR reaction for every people you want to diagnose, you just pull together a bunch of samples and you test with a single PCR reaction. If the result is negative, then you say everyone is clear. Otherwise, you test everyone individually. At least that's the type of scheme that is used mostly in practice. The thing is that when prevalence is low, that hugely saves capacity, so increases your capacity of testing. This is old technology. It has 80 years. It had been proved that was efficient. It worked for COVID. We test in Israel. We validated this locally, or at least our colleagues from the Faculty of Medicine did this. And after that, we conducted a pilot. We piloted this in a long-term care facility. And the pilot was a success. Actually, we stopped our outbreak. And we did everything with a third of the amount of PCR reactions that would have been needed if tests would have been conducted individually. So this was a huge success. And with that, we increased artificially the testing capacity. And we found ourselves finally in the place in which we had more testing capacity that what symptomatic cases were occurring. Okay, so we had this extra capacity, and the government, and by that time we already had the trust of the government, they asked us to develop some sort of program to direct the search for asymptomatic cases. We conducted a pilot, and in this pilot, we already had the mobility data from Intel. We asked the government for granular data on the location of active cases, active COVID cases, and we combined this information in sort of with a logic of a compartment model to predict where, if you were to test people in the public space, where would you find more a higher incidence of asymptomatic cases? Okay, and for our engineers, the logic is kind of clear. We combine this in a what we call the active screening test, BACTEX for the acronym in Spanish, and this was deployed locally initially in the pilot, but very quickly expanded to nationwide use. Actually, it became like the pillar of the screening strategy in Chile. We implemented this text in the form of heat maps. It was implemented in the Ministry of Health platform. It was used by all HMOs in the public infrastructure of Chile, and it looked like this. Essentially, you would enter this platform, this dashboard, and you would be able to filter by day of the day, time of the day, or municipality. The idea was to help local authorities to plan in their testing drives. They did not only plan test drives, and test drives were essentially taking like a mobile PCR testing station and just putting themselves in public space and start screening people. They also did use it for regulatory purposes. Essentially, they will go and conduct revisions of health conditions in bar, restaurants, wherever there was a higher incidence for predicted incidence of asymptomatic cases. Okay, so this was a huge success. It was implemented quickly all over the country and is actually still active, although we are hopefully exiting the pandemic here in Chile. They are still using this tool to plan the screening in public spaces. Okay, and that leads me to the fourth initiative. The fourth initiative actually started as just by looking at the data of that we were using in this active search for cases. And in terms of the timeline, this effort started in March of 2021 when the vaccination rollout began in Chile. The vaccination rollout in Chile was unique in the sense that we could not ensure a substantive supply of vaccines, mRNA vaccines such as Pfizer or AstraZeneca, but we have a lot of supply of the inactivated virus vaccine Sinovac. So the strategy was essentially a mix, okay, with a large proportion of people getting the Sinovac vaccine, but also with a lot of people getting the Pfizer vaccine, mostly. Okay, and the thing is that we didn't have data about the efficiency of these vaccines. So essentially what we did was we put together this dynamic IgG surveillance study. And again, as I was mentioned, this started by looking at the data that we were using from the active screen search. We soon realized that if you put, if you were smart to select a few spots, for example, in Santiago, and you look at the composition of the people that you were testing, if you were to test in those spots, you could get a high representative sample from the whole city. Okay, so that solved a huge problem in doing these population level studies, which is actually getting a representative sample, and a solution that didn't involve just going door to door, knocking doors and testing people. So we implemented this a pilot in Santiago with the support of the Ministry of Science that helped us broker a donation of 20,000 IgG rapid tests, and these are antibody tests. And I have to mention that these IgG antibodies are a first layer of protection. They are not equivalent to protection, but it is a first layer of protection against COVID. It's the first one that rises up. So we used this test, and eventually the pilot was successful. We went with a national implementation, and there the tests were provided by the government. Okay, and we had to train hundreds of people because we were simultaneously testing people in 30 cities across the country. And we had to, we use a web formulary that allow us to get, for example, addresses exactly without having to georeferences them later. The location of the stations to get a representative sample or to maximize the representativity of the sample was conducted through integer programming. So that's a nice use of OR in this project. And I want to show you this is the deployment. Here is essentially showing that we were actually in a lot of places in Chile. That in the lower left corner of the screen, you see the flyout that we were using, saying that the study was free, was anonymous, and was voluntary. It was not diagnostic in the sense that these IgG antibody tests, they're far from being as good as the gold standard, the PCR gold standard, although PCRs are for diagnostic. The effectiveness, the individual precision of these tests is not as good as we would like to, but for conducting population level study, they work. Okay. And this is the type of results that we obtained. This is the IgG positivity among Sinovac recipients during the first dose and the second dose. This is true time. The x-axis shows weeks elapsed since vaccination, the first doses. And we'll see that with the first dose, there is no much reaction in IgG positivity, but starting on the third week after the second dose, we have a huge jump to 80% IgG positivity, and then a steady decline, and a steady decline that is up to, let's say, 6 months. Okay, and this is not unexpected. This is the kind of curve you would observe in an activated virus vaccine, such as Sinovac. What is remarkable here is that the curve for Pfizer is quite different, right? For Pfizer, you get a reaction even with the first dose. With the second dose, you get even higher results, and then the IgG positivity is actually, it presents a little bit of decline, but the decline is very, very, very mild. Okay, so that's a huge difference between these two vaccines. This was the first piece of evidence that had a direct comparison between these two vaccines with these two type of technologies, and actually suggested the idea of applying a booster dose on Sinovac recipients, and in particular with elderly people, because I didn't show that result, but our results show that the decline was more pronounced on elderly people relative to the younger population. So essentially, this was a piece of information that the government had at hand when deciding, taking the decision of applying a booster shot decision. Relative to the US, I think we started 2 to 3 months ahead of time before the approval of the FDA of the Pfizer booster dose, which put Chile as a leading country in terms of booster dose. We set up an econometric model to measure the effect of advancing this decision, and actually are very confident in that our econometric model says that we saved thousands of lives just because of the decision of advancing the vaccine. I want to end with this because this is representative of the effort, and I'm going to take just a couple of seconds more. This picture shows, this is of the reprisal of the Edelman presentation. I want to highlight 2 things. First, even though we have won and we have all reasons to be quite happy, this is the type of ambient that we have in the audience of seriousness, because it was it's still a very delicate issue. And second, in this picture, we see the director of the research institute. Then we have the Undersecretary of Public Health, which is essentially is the Chilean Fauci, if I have to read somewhere. Then you have the Ministry of Science, the Minister of Science, and then you have the CEO of Intellocean, which is the telecom company. So this is the type of support and unity that we displayed with our research, and for that we're very proud, and we're very proud of having received this Edelman Prize this year. And with that, I'm stopping here. Thank you.
Okay, thank you very much, Denis. Thank you very much, and again, my congratulations to you and to your team's achievement with winning the prize. Very great. I'm going to proceed immediately with introducing our final speaker of today, Adibah Shuib. Hi, good to see you.
Hi, yeah.
Welcome. Adibah has a PhD from the University of Birmingham in the UK. She's affiliated with the Technical University of Malaysia, is president of the Malaysian OR Society, and she has a broad interest in location and allocation and routing problems, and I guess that is going to be reflected in her presentation today. Adibah, please go ahead.
Thank you so much. Yeah. And I don't know whether it is a good afternoon or good morning to everyone. Yeah. I think good morning to all in USA. Yeah. Okay. So first of all, I don't want to disappoint everyone. Yeah. The title is actually the two-stage mathematical programming model ambulance routing problem. Yeah. But actually, this one is done pre-pandemic actually. So, but I hope that it will still relevant, yeah, in terms of its purposes in reducing the ambulance response time. So, first, I would like to just highlight the importance of ambulance services during pandemic COVID-19 and share with you the two-stage mathematical programming model for ambulance routing problem and a bit of conclusion. Yeah, so I think, well, we had this COVID-19 pandemic since 2020, yeah, at least. So based on the WHO, yeah, so we had these stages, yeah, for the emergence of the coronavirus, yeah, and the pandemic COVID-19, where it emerged in as a known virus, yeah, and then followed by the stage 2, the pandemic, and where it accelerated, and then we have the multifaceted pandemic, yeah, or with all those uncertainties, yeah, unprecedented symptoms and all sort of things, yeah, and finally we have these medicines, yeah, that hopefully can tackle the problem of pandemic COVID-19. During the pandemic COVID-19, we have all these terms come up where we have, first of all, deal with the coronavirus with the term COVID-19, with all the misinformation about the virus and also the pandemic terms, and people went through the panic buying, quarantine, social distancing, and self-isolation. Okay, so as for the Malaysia, the government has actually come up with a lot of efforts, yeah, to curb the COVID-19 outbreak that include closing the schools, yeah, universities, yeah, and also the offices, yeah, and we also closed the border, yeah, for foreign visitors, no religious activities, and those returning from overseas have to be quarantined for 14 days. All shops except businesses, yeah, have to be shut down, yeah, no social gathering, and all sorts of actions have been taken, including the movement control order, in order to stop the pandemic COVID-19 from spreading in faster rates. Yeah. So as you can see that in December 2020, the number of cases was only 113,000 in Malaysia, yeah, with a small number of deaths. But in 2021, it accelerated, yeah, where the number of cases jumped to 2 million with 31,487 deaths. And for recent statistics, we have 4 million, over 4 million cases, and new cases with 35,000 number of deaths. But with the dose given, yeah, we have 2 doses and also the booster that helps out in terms of reducing the number of deaths. As we know that ambulance services, yeah, is vital in terms of providing emergency medical care, in terms of responding to emergency calls and providing the medical transport, and the EMS ambulance service particularly is very pivotal in delivery of urgent and emergency care. So the COVID-19 posed many challenges, yeah, especially after it was given the pandemic status 11 March 2020. And then we can see that the ambulance services being the forefront in terms of providing, yeah, the services and handling, yeah, or managing the extreme levels of demands because of the crisis. So despite that, we have these operating models of the ambulance services being transformed. We have digital solutions being introduced, and then workforce number, including the volunteers, yeah, have to be counted in, and we have processes, yeah, that maybe before this were unimaginable, unattainable, and suddenly become achievable at great speed because of the needs. In Malaysia, for example, yeah, we have doctors and nurses, the frontliners have to deal with the huge responsibilities of taking care of the sick people because of the COVID-19. But at the same time, we have all the teams, yeah, for the ambulance services. They also work tirelessly to ensure patients get adequate pre-hospital treatment and safely transport to hospital. And during the COVID-19 pandemic, we also have, yeah, the role of private ambulances, where in average 50 to 60% of the response calls to them, yeah, involve transporting the patients under surveillance, yeah, or confirmed positive cases to the quarantine centers. Okay, and there were times also, yeah, when there were bottlenecks and hospitals and ambulance services have to struggle, yeah, with the huge number of calls, yeah, but at the same time limited resources. Even the teams for ambulance services, yeah, many of them have also been infected with the pandemic, with the COVID-19. Okay, as for the guidelines to handle, yeah, the patients, yeah, or the infectious disease patient in terms of COVID-19, yeah, the Malaysian government or Ministry of Health have come up with some guidelines, which include finding the right ambulance for transport, preparing the ambulance for transport, and deciding how many patients should be transported in the ambulance, and then terminal cleaning, yeah, or decontamination of ambulance, cleaning and disinfections of medical equipment, and also personal protection equipment for personnel involved in transport of the suspected or confirmed infectious disease patients. Okay. So at the same time, there are certain policies that have been actually outlined by the government that to make sure ambulance services play a major role in ensuring patients being given the appropriate care for their needs. And also, this is out of responsibility that the ambulance services is crucial components in the change of survival. And it is of utmost importance for the Ministry of Health to ensure the services are delivered in safe manner. And also the land ambulance must be mainly maintained in safe and reliable operation conditions. These are all the policies before and during the COVID-19. Okay, so let me just share the study that has been carried out in terms of the two-stage mathematical programming model for ambulance routing problem, which was basically submitted for other purposes, but I think hopefully this will also be useful, as presented in this webinar. Okay, so basically this is about improving the ambulance response times, where the study was carried out for the city of Shah Alam in Malaysia, and the two-stage multi-objective binary integer programming model has the objective to minimize ambulance travel time and also travel distance, from hospital to emergency sites, and also traveling back to the hospital. The Solomon benchmark instance has been used to actually come out to simulate the random emergency sites, and we have used the Excel solver and also MATLAB and the preemptive programming approach, Go programming approach, in order to solve the model. And there are 8 scenarios used to solve these particular models, and then we have the combination of the findings of these scenarios to come up with the final parts of these results. And from these results, we have the scenario 1 and scenario 5 on non-peak hour without penalty cost produce the ideal results that is expected, and whereas the scenario 4 and 8, which involve peak hours with penalty cost, represent the worst case scenario. Okay, so again, when dealing with ambulance routing problem, there are some terms that need to be considered. That includes the activation time, that covers the period from the receipt of the call and to the mobilizations of crew. And then we have response times covering the period from the receipt of calls to the to arrival to the ambulance sites, and also patient care time, that is time to travel back to the hospital. So ambulance response time has been used as indicator for the services. And for some countries, actually for all countries, they have different ways of recognizing or the differentiating between calls for emergency services. That includes categorizing these calls under life-threatening, for example, emergency, urgent or non-urgent, and that depends on the countries. And optimal solutions to ambulance location and location problem and ambulance routing problem can contribute towards reducing the ambulance response times in general. So the goal of the ambulance routing time is to determine the most effective routes for ambulances for emergency requests in disaster response situation. So the motivation is that in Malaysia, the ambulance response time is still large, as compared, or is high as compared to the international standard response time, which is 10 to 15 minutes. And this can be said as contribute to the fact that only 0.28 ambulances for every 10,000 people, according to a study. So the motivation is to provide to increase the increase of population in urban areas where traffic conditions dynamically change, that actually influence the response times. So that affect the patient's survivability. And as urbanization make rapid strides, we also have frequent traffic jams during peak hours, especially, which cause the ambulance to have hard times to reach the destination or go back to the hospital on time. And we have the idea of providing much better or more effective healthcare services to the improved emergency ambulance services. So the goal of this particular study is to construct the route network, for the ambulance services within the city of Shah Alam, to formulate the mathematical programming model, and also to propose strategies out of the optimal solutions of this model. And the scope is actually, the study only focuses on the government ambulances under Ministries of Health, and also here we are using the mathematical programming model, and also solving the model using MATLAB and Excel optimization solver. Basically, we use the Solomon benchmark instances to come up with the simulated random emergency sites. And as what we have in this study, we actually didn't include the activation time, that is mobilization of the crew, and also time in between during the pre-treatment at the site before traveling to the hospital. Okay, so what I would like to share is that basically what we have here is that the road network covers an area of 20 kilometers by 60 kilometers in Shah Alam, and the nodes, actually the emergency sites, and also the arcs, the road segments. And the data include 191 nodes and 592 arcs or edges at the road network. Okay, and we deal with peak hour and non-peak hour. Okay, and this is actually the look of the road network. And we have categorized the situation here to those sites in less than 10 kilometers, 10 to 20, and also greater than 20. So as again, I mentioned about 4 different situations. Situation 1, 2, 3, 4, and we have 2 models. The first stage, which is the first stage, and also the second stage. So therefore, we have 8 different scenarios. So these are the scenarios, and these are the notations for the model for both stage. So we can see the travel time to ambulance emergency site, and also the distance, and also going back. And then what we have here, we also look at the situation of combined of this 2-stage model, and we would like to see the total travel time and total travel distance that is for the full journey. And the time performance represent the optimal travel time from model, and also optimal travel time that can be sought from Google Maps. Okay, so I am going to just browse through this, because the writing is too small for me to read one by one. So as you can see, these are the results for different scenarios. I will just go straight to the summary. So as I mentioned, we have 8 scenarios basically. And then we have the combined results, where we combine the 2 models, the first stage and the second stage. Okay, and also we have this summary of the full results. Okay, let me just present this. Okay, these are the results of all the scenarios, scenario 1 to scenario 8, based on the 3 different categories: less than 10 kilometer, 10 to 20, and above 20 kilometers. So we can see that category C1 can be reached less than 10 minutes. The worst is less than 15 minutes, and category C2 it is actually between 20 to 25 minutes, and also C3 it can only be reached within 35 minutes or 40 minutes in the worst scenario. And then we have the combined travel time and also travel distance for category C1 which is less than 10 kilometer. So we have this according to non-peak hour and also peak hour, without and with penalty. So as you can see that the results here, For the distance less than 10 kilometer, we have, it is between 20 to 30 minutes. This is a full journey, and then that means to the emergency site and back to the hospital. And we have 40 to 50 minutes and 65 to 70 minutes. So if you compare this with the international, definitely, even for the one way and 2 ways, coming back to the hospital, they are actually far higher than the international standard time. So as conclusion, there are some if the objectives are achieved, so there are some improvements that can be suggested, to improve further the model. But as the main conclusion in relation to the pandemic COVID-19, we know that ambulance services is the forefront of for caring patients, especially to cater for the extreme level of demand placed on the 999 emergency services. And actually, the COVID-19 pandemic has the biggest challenge, has been the biggest challenge ever, not just in Malaysia, throughout the world, and nobody has expected this. Ambulance services include transportation of positive COVID-19 patients that were severely affected and need extra attention and treatment in hospital, other than those patients under surveillance or confirmed positive cases to be sent to the quarantine services. There were service findings that revealed that ambulance service personnel have been the worst impacted, where 77% stating their mental health has gotten worse, especially having to deal with the huge demand and responsibilities dealing with the affected COVID-19 patients. Okay, the pandemic has introduced a unique set of circumstances, and that actually improved the EMS services a lot. And this study, despite not carried out in the context of pandemic COVID-19, have the potential to reduce ambulance response time further, with benefit to patients in general. That's all. Thank you.